important to talk about this very, very relevant topic, which is becoming more and more rampant in the modern society, is pain management in a chronic, and why it gets chronic, and when it's neglected and all. We'll talk in length about it. The chronification of pain, central sensitization. Then we'll talk about the multiple joint pains and a little more chronic pains. Although it's very, very difficult to cover the topic in this 1 hour, maybe 1.5 hours. But I'll just try to wind up in 1 hour time as much I can. Rest we can take up some other day, some other time. So as we know, pain management is a human right. But when we say it's a human right on part of the patient, it becomes all the more imperative on our part that it becomes our duty to deliver this pain relief to this patient who are suffering day in, day out, even in hospital settings. Yeah. So pain is as old as mankind. We all know it, but still is so mysterious. So much work has been done in the through the ISP, which is International Organization of Study of Pain, and so many modern advances are going on in the pain management. I think it's very difficult to catch up, but yes, one has to spend time and get used to this latest know-hows and make use of it for the patient care. That's what we're looking at. Though we talk about the pain in the Time magazine and the Business Week and other places, conquering our pain, and you understand why it's so important about pain. Because pain is a pain. Then patient may come to hospital. 50% patient come to the hospital with a pain, and it is our duty to understand: is it one of those pain which can be best dealt with the other departments, or it's a chronic pain which is mysterious pain which really needs a pain specialist care? That's where pain clinics are, world over now. It is imperative part of any hospital for certification to have a pain clinic in Western world, or even in China for that matter. Yes, why it's getting more common in younger age group? It used to be an old age problem, but in younger age group, because of the lifestyle changes and what is happening with these computers, with mobiles and whatnot, WhatsApp menace and all, people are now getting into posture which human body is not used to through our evolution, which is in thousands of years. Now this revolution has happened in a decade or 2 or 3 decades. So we are getting more used to this new technologies, and that's where body is not able to cope up. Let's see. This is about when we people work for hours together or days together, like I was preparing for hours together. So there's bound to be some insult to the body, and that causes the fallout, which is the shoulder pain, low back pain, neck pain, and disc pain, and other pains for that matter. And young people who are coming because they travel long distances. They go to the hospital, the workplace, and they sit for hours together. The advice is do take some break, make some changes, posture changes, do walk around. But most important is keep your posture tall as soon as possible, and a spine in S shape instead of C shape, because that is where the whole thing goes wrong. Now this chronic pain is associated with many conditions, and low back pain or back pain for the matter is the commonest. Now it is becoming not only low, the upper back pain is also getting more commoner because of the WhatsApp and computers. Osteoarthritis, we know, we're going to talk about it today. Headaches, chronic headaches, we'll take it some other day. Migraine and fibromyalgia and other conditions or other arthritis for myofascial pain syndromes. Now we know the age expectancy is increasing world over, including India. And more the age, more are the chances of having a chronic pain problem. And that's what the projected rate is, that we have to get more and more older people to deal with the chronic pain, and we have to manage because they're going to live longer. And that's what it is. And it becomes more difficult to treat older people because of many other reasons, comorbidities and all. Like take an example of osteoporosis. Like people who have osteoporosis, they have a vicious cycle, and there is increased mortality, morbidity, and in all parameters they do worse than the other cohort population. And that is why it is very important to treat osteoporosis in its own right, because it can cause back pain by itself, or bone pain for that matter. Yes, we have got very good molecules available these days, like teriparatide, denosumab, along with the bisphosphonates, D3, calcium, lifestyle, some sun and all, everything together. Exercise, routine exercise is very, very vital. So more you do all this care, better it is for us all. We all also getting to that age now, 60 plus, we're going to have these pain problems coming up. Now another is why it's so important to talk about pain is because pain is often under-recognized, under-reported, under-assessed, under-treated. So there are multiple barriers, which is at the hospital setting, patient setting, the society setting and all, and that's why there is called oligoanalgesia, which is failure to recognize and treat the pain properly, which causes the chronification of pain. The duration will matter. Less than 3 months, less than 1 month is acute, less than 3 months is subacute, and more than 3 months become the persistent chronic pain. Now understand, chronic pain is not just a bodily pain, and it's not a useful thing. Any acute pain is okay, it's a secondary trauma, it's a defensive mechanism. It gives you a caution, and you cure it, and the cure rate is high. But if it becomes chronic, there are many reasons for chronic pain, and there is another thing is there is a right shift on the part of the pain sensitivity, and patients which normally is not supposed to be a painful area, it starts perceiving this as pain. Allodynia we call it. A normal touch is taken as allodynia, and the normal small pain will which is aggravated is called a hyperalgesia, and that is in a pain response. So we don't want this to happen. That's why it is important to treat pain in initial settings, initial few weeks. Otherwise, there is a chronic sensitization, which is the central sensation and peripheral sensation. It happens at the peripheral levels, it happens at the spinal cord level, it happens at the brain level, and there's so much thing going on. I'm going to give you a little glimpse of what is going on in these patients. In chronic pain patients, they are different body altogether, different mind altogether. Their substance P increases in the spinal cord levels. Their brains get more sensitized to the pain, and this somatosensory cortex, the functional MRI changes are there, and the peripheral chemical also changes. Along with this, one more thing which is happening is neuroplasticity. We'll discuss it in a minute's time. So chronic pain is already been defined as a disease by itself. It's not just a symptom by the WHO and the UN and human rights bodies. So pain is not just a physical dimension. It's not just a physical pain. Pain is a functional pain, which is a psychological part of it, emotional part of it, spiritual and social part of it. People keep suffering, they run away from society, they get more introvert, they start avoiding, avoidance is there, start away from work abstinence is there. And in Indian setting, very important point is the financial aspect of it. Because obviously we don't cover for the pain. Like in Western world, they have a work compensations. We don't have this compensation part here. So people keep suffering on money point of view. If some working person of family, the bread earner, gets into pain, is not able to earn, the whole family suffers. And it's a widespread pain phenomena. It's not, means we really have to patient keep coming with all these kind of things. The shoulder pain, there are about 5-10 phenomena here, and there's a lateral epicondyle elbow pain, the wrist pain for that matter, and the upper hip pain, the knee pain, and the ankle pain, and the spine pain and cervical pain. We're going to talk them one by one during this course of the lecture. Let's give you some glimpses of some examples. In the upper limb pain is the carpal tunnel syndrome, cubital syndrome, thoracic outlet syndrome, Raynaud's phenomena or vascular phenomena we call it, rotator cuff or shoulder syndrome, T-equivalent tenosynovitis, very common, or other tendinitis, tendinosis are there, trigger finger and ganglion. These are few examples, but we keep seeing them routinely, so I'm just labeling them. And it's not just the nociceptive pain which is there. Many times, if they're not treated properly, they get into neuropathic pain. So nociceptive pain is, we know it comes from the tissue. It is realized by the nociceptors by the tissue. But neuropathic pain is not just coming from the tissue. It is a nerve which is crying of pain. Nerve per se becomes the carrier of the pain, and that's a neuropathic pain. Like in cancer scenario, diabetic polyneuropathy, we all know about it. The phantom limb pain or stump pain for that matter, post-herpetic neuralgias. The CRPS is very dirty entity. That's why it causes a regional pain syndrome, chronic one, which is complex, which is also called chronic complex regional pain syndrome. And fibromyalgia, another bad entity, which is known now that it is there are cell changes which is going on. The pain can be nociceptive versus neuropathic. There are many examples, but there are mixed pain also. Like low back pain can be mixed pain. Knee pain can be mixed pain. It can be nociceptive as well as the neuropathic component. So we have to kind of address all components. If it's a pure somatic pain or nociceptive pain, treat with the NSAID and other drugs. But if it's neuropathic component is also there, then we start adding neuropathic medication, and we know there are different set of medicines. I'll just explain them in a minute's time. Like this is a nociceptive neuropathic, and I just mentioned about the nociplastic pain or neuroplastic pain, because here the brain inhibitory pathways are not working. So any signal which is carried antibody that has not been countered by the negative impulses from the brain, or which inhibitory pathway is not working, which kind of controls the excitatory pathways. So that's the hyperexcitability of the tissues which becomes, and that becomes more dirty for this patient. We know cytokines are known for as pain molecules, and the patient feel bad, and it's not just the body pain. It happens in other dimensions also, like a poor sleep, fatigue, anxiety, dizziness, nausea. And we have to address, you keep seeing these chronic patients very often. Even immune system is getting implicated now with all these things coming up in the CNS. So there is a vicious cycle. All these things of chronification pain is happening. It's important to treat it. Important to treat. Why I'm highlighting all this in first 5 minutes is that it may make a patient disabled. There is some pathology, but is an exaggerated response on part of the patient and body system, or for the matter mind. So we have to take a multimodal approach in such patients to treat them from all points of view, like pharmacotherapy or physical therapy for the matter. There's a very, very useful thing. Or interventional approaches which we kind of help in many of such patients, and they do work. They will decrease the pain part, decrease the medication part, and decreases the timing of the disease also. Exercise is good. Lifestyle changes are very good. Psychological sports is very, very important, and here family really comes in a big way. And their complementary alternative medicines are there. But I'm not talking about quackery now. I'm talking about alternative medicine. They are very, very useful. Idea is find the cause of the pain, treat the cause, find the changes which is happening, treat the local pathology, and what is happening on part of the individual or impact on the individual, minimize the impact of the disease. That's called minimize the suffering on part of the patient. We know all about medications. They are there in a WHO ladder or pyramid of pain, and which starts from the lighter medicine like NSAIDs inhale all, then lighter opioids, stronger opioids, then IV or subcutaneous or pump for that matter, and last is the neurolytic blocks and intrathecal pumps. Surgery is last, way above, way ahead of it, and it may be associated with surgery. Sometimes they go parallel, one after the other, or together for that matter. We know painkillers are harmful for the patient. They can really do. We know 50% of the lysis units are filled with the analgesic nephropathies. Along with the diabetes, if it is there, then obviously it adds fuel to the fire. And then is the gastric bleeds. We know massive gastric bleeds may happen, or ulcers are known to happen. And with the narcotics, these drugs do affect the brain power or cognitive power for one part of the patient. Very good thing has happened is we have these molecules coming up, tramadol, tapentadol and all. They're really helping in a neuropathic and nociceptive pain together. And they're very, very useful. It's said it's a centrally acting analgesic. 30% action is because of the ascending pathway, 70% action is because of the descending pathway, which is very, very important. Or modulatory pathway, modulation is there. Pregabalin or gabapentin are very good. Alpha 2 ligands are there, calcium channel blockers are there. They're very, very useful molecules. Use them day in, day out. Very, very helpful in scenarios, even in like arthritic patients, chronic knee pain patients, or chronic back pain patients. They are very, very helpful because after all the pain is carried through nerves only. So these things do help along with other medications what you're trying to do. Yes, doing all this sometimes may not give some adequate result. That's where the interventional pain management comes into the play. And it is really doing good for a good number of patients. But it has to be rightly timed after adequate conservative management is there and is not really giving adequate results. There are some unacceptable side effects like trigeminal neuralgia. The drugs is being given and patient is not happy with the drugs, either not responding or side effects are there. That's where you have all these interventions coming up. And the one RF does the whole thing, whole needful thing. Same way in joint pains also. These days we do RF and they give a very good result with the knee, shoulder and hip for pain for that matter. And another entity which is important is chronic pain can be sympathetic mediated or sympathetic maintained. And there are many such examples which happen in such patients. Do recognize it in time and treat it. And that's where it has some other associated features like fatigue, sleep disturbance, irritable bowel syndrome, or interstitial cystitis, or we have headaches, TMJ syndromes, or subjective swellings, or paresthesias. And definitely we have to diagnose and add value to them and treat it. Now CRPS, I mentioned you earlier, a very trivial trauma is gone, must have healed, and patient still having a continued pain. This is called a complex residual pain syndrome. Very known entity after a ankle sprain or even a wrist fracture known. Then we give a sympathetic block and they respond truly very well. like in a stellate ganglion block or T2, T3 sympathetic block, or in the foot area, we give a lumbar sympathectomies and they respond well. Like I'm going to talk about knee pain now to begin with. One of the arthritic pains which is there, which is very, very common, and almost 50% of the older age people are having a knee issue. Now, it's all knee issue is not intra-articular or arthritis for the matter, end stage arthritis. Many pains are peri-articular, or they should be looked in, especially younger age group. And there are so many reasons like ITB band syndrome or Passen's sinus bursitis, or for the matter all those osteochondritis dissecans or chondromatia petali, petrofemoral syndromes. Means there are so many, or middle kind of meniscus part of it. It's not that everything is cartilage is worn out. Sometimes it is just a tear, sports injury. These are known things, and they all are treatable either by medicines or physio. And these days we have a very good modality is the PRP or regenerative medicine, which does very good for such patients, and is really meant to relieve and maybe repair back to normal. That's the best part. But yes, if it is a bad knee and patients having pain, act timely and wisely. I definitely try to send them for TKR if it really demands TKR in such patients. Yes, what we do sometime in intra-articular scenarios in a patient who are not too bad and doesn't need a TKR in reality is we can start with steroid, with ozone, with LA. I do it very often with visco supplements. We have already started doing, although steroid is not too good too often. But then we have a platelet-rich plasma or regenerative medicine, and now we have exosomes also, or growth factors. They work very good. It's not always that it has to be PRP. Botox does help because it kind of takes away the nerve endings signaling also in body on many parts of the body. And then prolotherapy, as I mentioned you, for dextrose or ozone, prolotherapy works. Extra-articular, yes, we have steroids, we have PRPs. Now, other important thing is the genicular nerve interventions. Now, where we do a genicular nerve RF, we can do a chemical also, but RF is the one which really works in such patients. In rare patients, we might need neuromodulation or intrathecal pumps for other reasons, not just the knee. Now, the knee, how to address knee? Normally, when there used to be blind procedure, we used to go the upper outer quadrant was the one. Now, with the advent of the ultrasound, we don't have to do anything blind now. We can just have a look at the screen and just go inside. If there's a Baker cyst, we can deflate it, put in medication, and if it is intra-articular, we can just put a probe there, have a look inside, and get to the right spot. It is studied that if you don't do a ultrasound guided work, most often you're not inside the joint space. You may be one of the tissues and you are injecting in the tissues, which is not a great idea. There was a study which was done which showed that comparison between the steroid injection vis-a-vis RF, cool RF especially, and they found the cool RF any day is better than the steroid injection. And that's where many of these patients who are chronic pain, knee pain, doesn't need a TKR or can't go for TKR, they are the one who really get help with this cool RF. Now, why cool RF? It gives a bigger lesion. And it gives a lesion at the upper medial. There are so many nerves now. It is more and more getting added day by day. But mostly are the superior medial, superior lateral and inferior medial nerves which are there. But there are smaller nerves also which can be targeted. And we have now the IPAC block, which is the posterior knee block, which is not the cool RF. It's a chemical or RF thing, but it works very good. Now, these are the few places where we tend to mostly put our probe in there and do a cool radiofrequency denervation. And anyway, by doing denervation, taking the pain away, and you're not correcting the pathology. To correct the pathology, you have to do your needful, whether do a PRP or exosome, regenerative medicine, or might have to go for a surgical correction, right? But it does not mean that when you do RF, you're not doing other things. You can always do a visco supplement and other needful things. Yes, to maximize, but RF will take away the pain part of it, and that's more vital for such patients. The functional improvement is there after the pain is taken care, and they start more mobile they are better is tissue repair. Cool RF is coming big way in other places also. Beyond knee, we got a SI joint, in the hip also, and that's where we're going to talk about it today, and that's where it helps. As I told you initially, all knee pain is not intra-articular. Sometimes there is an extra-articular pain, and we have to address those nerves, those pains, smaller nerves, and that's it. RF can be helpful in body in many places. Like there's a big list of it. I'm not going to talk about this big list, But frankly, if you have an RF in your OT, you can address many pain syndrome which are not able to address otherwise, because RF will take away the nerve signal or the pain signals, and disease treatment carries on side by side. And like we got about stellate ganglion blocks, phenolpentine blocks, suprascapular, intercostal nerve, laterocutaneous nerve thigh, supraorbital, infraorbital nerves, pulse RF for the maxillary mandibular, or DRG for that matter, splanchnic nerves, hypogastric, impar, intraarticular trigger point sometime. Yes, RF is useful. We do a pulse RF, conventional RF, and we do a cool RF now. There are many RF techniques. And now there is called a cryo also technique is also there. Cryoablation of the nerve which is there, which is cooling of the nerve, freezing of the nerve, and making it kind of defunct for few months. Then SI joint, the RF or discogenic pain can be taken care with the RF. Now, just give an example. There are people who keep suffering because of the trigeminal pain, and they have been treated by the dental people, and they half the jaw is eaten up, and then realize it's a trigeminalgia, and then patients send to us. With just one RF is all that you need to do. But idea is recognize it in time before it becomes too late and your half the jaw is eaten up. That's unfair. That's where it has to be taken care of. Now this is about the shoulder pain. Now the next joint is the shoulder, which is very common problem and less often realized, and people keep on doing physios and nothing. Great, but sometimes do wrong physio. If there is a muscle tear, more movement will cause more muscle tear. If it is a periarthritis, exercise is good. So that's what it's realized. And that's where we call it either there's a impingement syndrome, subacromial impingement, which is common, or painful arc syndrome, or there's adhesive capsulitis. And there's a different treatment for them. So realizing the pathology is important before you give a targeted, right, effective treatment of these patients. The idea is there is a progressive supraspinatus tear cascade which is there. If there is a tear and you keep exercising more, keep putting more pressure to it, there is a complete tear. Partial tear will convert to complete tear. Other time a partial tear can convert to complete tear is when you do a intra-tear injection. So all injections to be done in shoulder has to be ultrasound guided. Never ever inject inside any tear, like inside a muscle, inside a tendon. It's not done. Steroids especially, and you can do it around. But if it comes to PRP or EGen, you can inject inside tear. That's where the repair is going to happen. And this is the difference. When you do a supraspinatus tear injection, steroid has to be around for bursitis, but PRP has to be inside the tear or inside the mass. Like in hip, knee and shoulder, there are so many chronic pain applications which is there. It depends which level you are addressing. Are you addressing at the axil level? Then you have to do these procedures like spinal cord stimulator, DRG, and intrathecal trunk deliveries. If you're working at plexus levels, then you're doing the plexus blocks. As simple as that. But if you're working at the peripheral levels, depending on which nerve is involved, you do the block for these nerves. Or you keep going more. Now lately there is a master stroke that they're doing a periarticular or articular sensitive branches of the mixed nerves even. Like the suprascapular nerve for that matter, or hip nerve for that matter, femoral nerve. They are taking the articular branches separated out from the motor branches and then burning them out with the radiofrequency or cryoablation. And that's what the whole idea is. The articular level, sensory branches, motor sparing effect is there, and I'll show you a few of these blocks. In shoulder impingement syndrome, as I mentioned I do 5-in-1 block. I go inside, put my needle in there and keep coming out, keep medicating this area. That's called a 5-in-1 block. Another such patient, we are doing a radiofrequency ablation of the suprascapular nerve. But here we do a pulse RF because it has got a motor component. But if you want to do a sensory component, which I'll show you after a minute's time, and that's where the nerve lies, suprascapular nerve under the over the suprascapular notch under the ligament. And that's where we are doing a sensory blockade. I'll show you what do I really mean by that. The shoulder is innervated by few nerves, and depending on which sector is the pain, that nerve is to be taken care. Whether it's going to be suprascapular nerve, axillary nerve, lateral pectoral nerve, or nerve to subscapularis, these all nerves, they have supply in the shoulder in different regions, and you block them accordingly in one or in combo. Like suprascapular, we don't do block in here because it has got a supraspinatus component, and we don't block in here because it's got an infraspinatus component also. So we block very close to the joint area, and that's where the articular branches are there. Look at this picture. It's called a sensory innervation of the human shoulder, and there are 3 bridges, and they are going more close to the joint and blocking these nerves, avoiding all the branches which is mixed in here. They are mixed branches, motor sensory, but they become all pure sensory in here, and that's where we are trying to block them. That's where the master stroke is. And it's been realized more and more often that we can really give good result to these patients, which was not done earlier. But again, one more thing is, you do a cool RF, you want to do bigger lesion close to the area of the joint, because nerves are now widespread, and you have to capture all these nerves or twigs for the matter, because they are scattered ones. So that's where the cool RF or bigger lesion is there. This is where you're doing a lateral pectoral nerve over the coracoid process. And that's where we are trying to put under ultrasound guidance. This works very good. We can do fluoro guided, but ultrasound guidance has come up in a big way and really helps. You can have a look at the image. We just sit on the glenoid area, glenoid ridge, and do our suprascapular. The suprascapular, which was originated here, has come as a glenoid and is given an infraspinatus motor branch. Thereafter, everything here is the sensory one. So we are burning or blocking these nerves which is sensory in here. And same thing we go for axillary also. The axillary nerve is supplying the deltoid and teres minor. After that, the nerve is going towards the joint. The ascending branches, they are all sensory, pure sensory, and we are blocking them there. This is realized, and this is important. Next important thing is the spine pain. Very, very common back pain, spine pain. Although I gave a talk last time about that, but today we're going to touch upon basic things about the spine pain. Realizing that this is more to do with posture. Like I'm trying to sit more straight in the posture, and I wish everybody who's listening to me is sitting straight in the posture. Otherwise, the spine keeps getting bad from. We have to make a S curve of our spine, which is natural curve. Don't make a C curve of the spine, which is unnatural, and that is very, very common in the couch and slouch area of people. And this is where the disc tears and gives a sciatic pain all the way. So there was a back pain, now is a leg pain very typically, or there was a neck pain, now is a arm pain very typically, all these patients. Like this for the knee pain, same goes for the back pain. You give NSAIDs, you give opioids, you go neuropathic medication, but there has to be a right combination. And we know about tramadol, tipentol, all these things. Narcotics we are not using all that often, but yes, in Western world it has been used. But pregabalin and pregabalin are very good, including amitriptyline, nortriptyline, and duloxetine. They are very, very good molecule for neuropathic component, and they really help these patients, which is very, very difficult to manage otherwise in some scenarios. Like in slip disc and sciatica, we have neurosurgical treatments, and they are about the percutaneous intradiscal decompressions without opening up the body, or just a needle discectomy you can call it, and they do good job in subset of patients. All discs are not to be operated, all knees are not to be operated, all hearts are not to be opened. You can manage with angioplasty. Same scenario happens in other areas of the body also, and that is to be looked at. So these are least invasive things. If I have a back spine problem, I like to go least invasive as far as possible. Same is with our patients also. And these are so many modalities available these days, like ozone or RF for the matter, bicoplasty or decompression just with the needle disc effects, or epiduroscopy. And new addition to this whole armamentarium is the PRP or regenerative medicine, which is very, very good for young people, early disc disease, and you reverse and make spine natural. That's what you want to look for, and they're very, very helpful in such patients. I'm not talking about endoscopy, discectomy and other things today, because we talked it last time. Like spine can cause joint pain. We have a spine joints, each two vertebra, they have two joints in the posterior facet, and one discal joint is there. So there are joint complexes there, and then you have the SI joint complex which is there, and they are known to cause pain. We do intra-articular, but more importantly, we do an RF. This is the faceted nerve. We do RF. One joint is supplied by two nerves, one above and one at level. So we block these nerves, and that's where PRP is good again. Remember, steroid is not great, PRP is good again, and that's where we do a facet RF. You are seeing the facet radiofrequency ablation of the nerves, and sometimes even surgery is not going to help these patients. Please understand. Then again, we have to go for a facet denervation or facet blockade there. And many times, we said 30 to 40% time, the spine pain, lumbar pain is because of the facet pain, or 50 to 60% pain in the cervical area is because of the cervical facet pain. So we cannot, or 20-30% time it may be to do the SI pain. We cannot leave them alone for want of a disc correction. You have to treat them in their own merits. The same way, spinal cord stimulator, everything you tried, it failed, it is not producing the adequate result. is the time to go for spinal cord stimulations or dorsal and root ganglion stimulations. They are new modalities, very, very helpful, but in the patients who failed all other conservative or interventions, it is for them. And this is the DRG, it's a new thing which has come in. Very good thing in the new block which is there. But little costly, so it's not for everybody. Yes, low back pain is a puzzle. Many times you don't know what is causing the problem. You have to do a diagnostic testing, examination, sometimes imaging, but even it may fail even after that. Then you do a diagnostic blocks which really proves the fact what is the prognosis, what is the diagnosis and the prognosis. Like in some patients, they have a rib tip syndrome. I've seen them. People come crying and they are not been diagnosed because unless you know it, how can you diagnose this? The two floating ribs can cause rib tip syndrome. Or we call it quadratus lumborum syndrome, QL syndrome. But you give a block, it works very good. And the patient is very, very happy, back to normal. Same way cluneal syndromes are there. They are known chronic pain patients. Another pain which is there chronic is SI joint pain, which I mentioned you earlier. And this is the area, distribution SI joint pain. And you do a study and you find out. If it is, remember, inflammatory spondyloarthropathy or arthritis, they have to be treated from rheumatologist point of view. It is important. What I am talking today is more of a degenerative or structural or mechanical joint pains. And we are treating in a different way. Although very bad inflammatory arthritis can still be managed for pain point of view from the radiofrequency and R modalities. But in general, they need more of medical management for chronic point of view. And this is the, you see this sacroiliitis which is there. We do a sacroiliac joint block, we do a PRP which is helping these patients now. And then we do a radiofrequency ablation of the SI joint and we denerve it and the pain is taken care. Although it's a little tedious, but it's a very, very good procedure in a bad sacroiliitis pain. And it really helps these patients. Another which is very, very common problem is the tailbone pain. It happened during the COVID times when people sat for hours together in the bed and they were doing some office work from home or watching television. So that's a bad position because the weight load goes onto the coccyx. When you're sitting in the bed with the leg stretched, so the coccyx start getting pain. Very, very common problem. Less often realized, and people, they have their coccyx cushions and all. But yes, it is treatable. Try 4 weeks, anything you want to try. Any pain less than 4 weeks can be tried, anything, but thereafter it becomes a chronic pain. You better start working on it more seriously and do some intervention if need be. Like in these patients, we are doing a impar block or we do a over the coccyx injection, which is either steroid or PRP. And do add on oxygen block if it has become a recurrent or if it's a nasty nostalgic pain which is there. And then you manage it for that matter. And there's a lateral hip syndrome, trochanteric bursitis. It's another important thing, less often realized, but yes, you touch your lateral hip and there's a big pain. There's a trochanteric hip syndrome, although avian could be there in some patients. Now, what we do is, on ultrasound guidance, we get into the joint and we do the, beautiful. We don't have to do anything blind now. We just see the joint capsule, go here, put a drug in there and it works great, just like that. It works great, you're putting steroid, PRP, again it's a choice, as I mentioned you earlier. Depending on if it's inflammatory, steroid. If it is more degenerative, then PRP. It's more like that. Or more structural damage, PRP. And that's all depends. Now, this is about another thing which is ductal apparatus which is there or bursitis is there. There's not only single bursa. Subgluteus minimus bursa, subgluteus medius bursa or under ITB is the major bursa, trochanteric bursa, which is large bursa. So we medicate it and they respond well. Otherwise, they keep suffering. I'm telling you seriously, they can't sleep on the sides for that matter. And this is the neuroanatomy, which is there is a supply from the femoral nerve, accessory femoral nerve, operator nerve, accessory operator nerve, and they're getting into the joint. And these days we're doing RF with a very good result in such patients. And we just block them with the cool RF or RF for that matter, and it gives a very good result. So it is meant only for the people who are not going to relieve the usual treatment, as I mentioned earlier. But yes, there we are. When you think and you can't help these patients, send them to a pain specialist, they will help these patients. And this is about the ITB or we call it snapping hip syndrome or ITB syndrome. And that's where we do a iliopsoas bursa, we do an injection, especially in athletes or runners, and this is easy. You ultrasound guidance, get to the area, there is a bursa, there is a very large bursa sometime. We give injection and they respond great. Why I'm giving these entities, because they are not going to be realized in normal clinical practice unless it has been talked. That's what the whole sensitization process is going on, and that's why I'm talking all this. This is about the ilioinguinal hypogastric nerves. They cause neuralgia, groin neuralgias. Not all groin pain is hernia pain. They can be because of the neuralgias, especially younger age group. And another pain which is I've seen, and you do a ultrasound guided block, works good. Another pain which is very, very commonly seen is a Neuralgia parastatica, which is later protein of thigh pain, which is because of the pressure, because of the tight jeans or tight belt or tight clothes. Especially younger age people who hang their jeans on their anterospinal spine, and that's where the nerve is going superficial. It's superficial there, gets pressed, and they keep getting this pain. You go inside, do a block, and tell them to wear loose clothes, and it works good. And especially upper outer quadrant or the outside quadrant of the thigh, there's a pain. Anterior lateral quadrant of the thigh is the pain or tingling or all those neuralgic sensations there. Few slides about the elbow and wrist pain. And that's about the, we just talked about the carpal tunnel syndrome. There are other things also beyond carpal tunnel syndrome. When we see the dorsal pain, there can be a synovitis, there can be a intersection syndrome, there can be ganglion, or most important is a decoherent tenosynovitis, which is happening at the compartment 1. And it's known, you just snuff box, you press it, and there's a pain, jump pain is there, and you just put in a drug, cure, very good cure. So these are patients whom you realize the pain for reason and treat it, and this is all treatable 100%. Same way in the volar side, we are talking about other things also, but most important is the carpal tunnel syndrome, and that's what we just see. This 3.5 quadrant of the fingers, they get this sensation, tingling, especially during sleep, very, very bad, and they get up in the middle of night, check for thyroid, other things, and then there's compression on the nerve, median nerve in the compartment, which is there in the wrist area, and that's where you kind of open up the nerve. The nerve is getting compressed. Look at the nerve is getting compressed because the flexor retinaculum, and nerve is swollen up in there, and that's where we call it a step sign. The nerve is coming here, coming from this is proximal, and that's where the retinaculum is there. Nerve is compressed, and it becomes swollen, painful, and very, very sensitive. Now, after all, his nerve is one which carries the pain, and if you touch a nerve, obviously, it's going to be a bigger problem. And this is where it is bothering these patients. And you test them, and then you give a injection. You open up, it's called a hydrodissection. You take a needle in ultrasound guidance, and you just make space around the nerve, open up the nerve, put in a little steroid or PRP or prolotherapy for that matter. And if you are efficient enough, you can open up the retinaculum. This is the retinaculum. One can open up the retinaculum also just with needle technique. And you don't have to open or do surgery for the matter. This is, I just talked to you a minute back. Decoherent tenosynovitis, yes, realize it, painful, very, very helpful. One injection works for years and maybe once for all, lifetime. Another such patient, which is the tennis elbow or golfer's elbow, or for the matter, pes instantis bursitis, or we call it tendocallis syndrome, or reticuloacral bursitis, or plantar fasciitis. All these are known entities. They are treatable. I keep seeing medial scapular border syndrome, many patients. They all are very, very treatable. Find the problem, find the trigger point, put in your steroid for once, and if it comes back, put in your PRP therapies, and they really get help. And then obviously you do the adjuvant therapies like physiotherapy and medication and rehab, and they respond very good. Yes, steroid is only one time, but it's peri-muscle, not inside the muscle I mentioned you. Same way, if you're doing a regenerative medicine, it has to be inside the tear, inside the muscle, inside the tendon. And that's where you're doing for your PRP. Same way, for the golfer's elbow is there, known entity. Some patients, because of their activity, these patients, they keep having these problems because of the specific repeated activity of the medial elbow muscles. As I mentioned you, this is the tenosynovitis, posterior heel pain, known problem. Patients is difficult, can't wear shoes, can't really walk for long distances, run, and you realize it, do ultrasound work, you do a Doppler study, vascularity check, and you put in a needle there, steroid or PRP. Absolutely wonderful results, which is there. Same goes for the plantar fasciitis, which I mentioned you. They are routine things, they are routine problems, and patient can't put the foot on the floor the early in the morning, and for a few minutes it is very very painful, and you realize it, you put in your medication, and they get beautiful results. So that's where we doing good work. You just your count your blessing, give them a pain relief, and one life to live. Ask them to maximize, live in a pain free way as well as possible. My friends, I always keep saying teaching is the best way of learning. So I keep talking and keep talking to my friends and keep doing my courses, training straight courses. I've done many of them. People come from world over for the training of these intervention techniques, and I love teaching and I love talking. And it's always good to dissipate knowledge. This is the Montreal Declaration, which was said pain relief is human right. I was part of that delegation, and it says, when I said pain relief is human right, as I say it is our duty also to deliver it. And if we're not doing for ourselves, we are doing for our generations to come. It is our medical and social duty and moral duty that we make this world pain free as far as possible, because pain is a pain is a pain. It's the most subjective symptom in part of the patient, and if you give a pain relief to anybody, you've done a most human job. Thank you so much, my friends. Thank you so much. Thank you for your time. Any questions? I'll be more than happy to answer, more than happy to talk, and let's see how we can maximize.
Thank you so much, sir, for
My
this
pleasure.
talk. And the doctors, if you have any question, please let us know. Delegates, doctors, if you have any question, please let us know. Sir, we have got some questions. That is the what other disorders are associated with chronic pain syndrome?
As mentioned, chronic pain doesn't come by itself. It comes with a multitude of problems. It comes with the psychological disturbance, sleep disturbance, fatigue, the irritable bowel syndrome, fibromyalgias, TMJ syndrome, headaches. And there's so much of add-on problems which happen with these. And same way depression. So say chronic pain and depression can go hand in hand. They are interdependent also to some touch or some extent. So that's where. And another thing which happen is in a chronic pain is the chronification will have a amplification of pain. The pain which is normally been tolerated by other people in chronic pain subject, they are not that well tolerated. So that's where it is important to treat them in an acute phase. Any pain for that matter, acute phase, because that becomes more difficult to treat. I keep telling people there's one pain in the finger, one in the cord, and one in the brain. After a month, one finger pain becomes 10 in the cord and 10 in the brain. And after 3 months, one in the finger, it becomes 10 times in the cord and 100 times in the brain. That treating one now in the finger is not good enough. It's like a phantom limb pain. The arm is cut and there's a pain in the same finger which is not in the body. Patient experiences pain because pain is being experienced by the brain, not by the body. So it's a brain representation of the area which causes pain. So that is why it's so important that before this pain gets into the head or it gets deep rooted, there is a simile, जितना पेड़ ऊंचा होता है उतने जड़ें गहरी हो जाती हैं. Higher the tree, deeper are the roots. Same way it goes for the pain. Chronic is the pain. More difficult it gets into the brain. More neuronal, add-on is there, or recruitment is there. More the neurochemical or pain chemicals are recruited, and sometimes there are structural changes. Another thing which does happen in some patients is that they are just a minute. In some patients is that they have this chronification pain is the sympathetic pain, sympathetics which are normally not meant anything to do with pain, somatic pain, they start conveying the pain signals. So this is a new thing which is coming, sympathetic mediated or sympathetic pain which is comes up. So this all and wind up phenomena which is there, which is happening up. So with all this at the spinal cord level, peripheral level, brain level, and add-on psychological issues. So this is what the chronic pain is nasty and bad about. So it has to be treated effectively. Yes, if it is not treatable, you have other modalities to reduce the chronification of pain or central sensitization of the pain, and that becomes important. So there are so many components of the chronification of pain, which I mentioned you right in the beginning.
Sir, we have find one question, that is, which physical exam findings are consistent with chronic pain syndrome?
No, see, when there is a chronic pain syndrome, there is a hyperalgesia or allodynia. I mentioned in the beginning, a normal touch will maybe be perceived as pain, and a small pain can be perceived as a big pain. That's called hypergesia. So these are the physical finding, or pressure for the matter. They have a pressure meter. Like a normal pressure is not a painful stimulus. In those people, they have a painful stimulus of a normal pressures. So these are, and plus cold allodynia. Those things are there, cold or hot. So they, when you put a cold thing on the something, it does not. They put a cold finger in the cold water, it perceived as a pain. Like somebody's got a burn, and you put something in a hot water, it will give you pain. So same thing happens with cold allodynia. So these are changes which is happening in these patients, and there are some lab tests, there are some higher studies which is going. There are some tissue biopsies also, like in fibromyalgia and other people, or connectivity disorders are which is there, but they are the later on. Initially, we start with their clinical symptoms and these smaller tests, which does prove that they have a chronic pain symptom. Like you put a finger on TMJ, we or anybody for the matter won't run, but that patient will jump off and stay away from the pain or the stimulus. So these are few, or like tennis elbow for the matter. You press it in a chronic pain subject, it's not only the area of pain. The point is the other body's area is also getting more sensitized because of the pain. So it's not only the local pain which is there, it's around and surrounding, and other structures also start getting more painful.
Thank you so much, sir. So, with your all permission, can we conclude the session here?
Yeah, if
Thank
you
you, sir.
don't have any more questions, then we are all good in here. And I wish that everybody understands the fact of the matter is that pain is to be treated
Yes.
in acute phase, treated to be effectively. And after all, this is the most human job, which I keep saying again, that do it, and it is doable. Pain is real and treatable. There is no merit in suffering, and there are so many modalities which are available which can manage these pains. Should be managed effectively, and that's what really want people to have this carry a message from this lecture. Yes, many people won't know about it, but it's getting more and more know-how is important, and that's what you want to do. Thank you.
Yes, sir.
Thank you.
Thank you so much.
Thank you, my friends. Thank you so
Thank
much.
you.
My pleasure.